Hello, everybody, and welcome. We're going to just take a few moments while people file in, and then we'll get started with our program shortly. All right, hello, and welcome officially. My name is Michael Burroughs, and I serve as director of the Kegley Institute of Ethics. And on behalf of the Kegley Institute at California State University, Bakersfield, I want to thank you for taking some time out of your evening to join us for this very timely event, Ethics and COVID-19, a moderated conversation. So our institute is collaborating with Kaiser Permanente on this event. And this event is the first of a series of events as part of a newly launched Kaiser Permanente Bioethics and Medical Humanities speaker series. And our goal with this series is to host engaging events with leading medical ethics experts, such as those we have with us tonight, and in turn to promote understanding and discussion of pressing ethical issues in the medical field. So I know tonight we're going to have many healthcare practitioners with us in the audience. And so for that purpose, I want to note too that this event has been planned in accordance with ACCME/CMA standards and is approved for 1.5 hours of continuing medical education credit and 1.5 hours of continuing education credit provided by Kaiser Permanente. And no persons involved in the planning or delivery of our content tonight have financial relationships with commercial interests to disclose. And to claim your educational credits tonight, just to note, there's going to be links placed in the chat, which we posted several times throughout this event and at the conclusion of tonight's session as well. So I just want to say thank you again, everyone, for being with us and being part of this conversation. And with that, I'm going to turn it over to Dr. Nate Olson, who's Associate Director of the Kegley Institute and also tonight's lead organizer of our event. So thank you very much.
Thank you, Dr. Burroughs. As you all know, COVID-19 has turned our lives upside down this year. From work to school to time with our family and friends, everything is different for us this year. During this time, you've no doubt heard many different opinions about how we should be living our lives. To answer those kind of questions or think about to guide our choices, we need good factual information. And that's one of the things that we'll be talking about tonight, providing some good factual information. But a lot of those questions, a lot of things that we're thinking about are also questions about our values, about ethics. And that's what our main focus is tonight, is thinking about the ethical issues that are related to COVID-19. We need to think about things like our responsibilities to others, achieving racial equity in our society. I'm very excited to be joined by a wonderful group of panelists tonight who are going to be talking about those issues with you and me. So I'm going to introduce each one of our three panelists this evening. First, we have Dr. Nimisha Amin. Dr. Amin is a pediatrician and pediatric nephrologist at Southwest Pediatrics in Bakersfield, California. She's a native of Bakersfield, but completed her undergraduate and medical degree at UC Irvine, followed by residency and fellowship at Mattel Children's Hospital at UCLA. After completion of her training in 2010, she chose to return to the community that she grew up in hopes of providing quality pediatric care to those who need it most. It's great to have you with us tonight, Dr. Amin. Next, our second panelist tonight is Dr. Keisha Ray. Dr. Ray is an assistant professor at McGovern Medical School at University of Texas Health Science Center in Houston, Texas. Her research focuses on racial disparities in health and healthcare and justice in biomedical enhancement. She has a PhD in philosophy from the University of Utah. Dr. Ray, thank you for being with us tonight. And third, tonight we have Dr. Christopher Meyers. Dr. Meyers is the hospital ethicist for Kern Medical Center and Adventist Health Bakersfield. He has over 30 years experience as a clinical ethicist and has published extensively on topics in medical ethics. He's also Director Emeritus of the Kegley Institute of Ethics. It's great to have him back with us tonight. and Professor of Philosophy Emeritus at CSU Bakersfield. Thank you for being with us, Dr. Meyers. Okay, so the format for tonight, I'm going to lead a discussion with our three panelists for about half an hour to 40 minutes. I have a few questions that I'm going to ask them. And then after that, after our initial discussion, we're going to open it up to questions from you all. So if you go to the bottom of your screen, you can see there's a Q&A button there. And with the Q&A feature, at any point during our conversation tonight, you can send in questions, and I'll be asking the panelists those questions during the Q&A session. So after our initial half an hour, 40 minutes of talking, then we're going to open it up to you all and answer questions that you have. Okay, so what I'm going to start with here tonight for the panelists is we'll hear a little bit from each one of them about what their experiences have been like in the pandemic. And I'm going to start with you, Dr. Amin. So thinking about what have your experiences been like as a healthcare provider over the last now 6 months?
Well, it's certainly been interesting, to say the least. I think that within the office, the primary focus for me has been to continue to provide quality care for our patients. Initially, that started out as learning how to do telehealth visits and all of the ins and outs of that platform. And then it became a transition to learning how to provide a safe environment for our patients to come in and receive in-person care. And of course, amongst all of that, there was learning how to be in a mask and speak in a mask and work in a mask for several hours in a row, which was a bit of a transition, as many of you know. And of course, just spending a little bit more time with our families, answering the questions that we could, providing that reassurance that we could. And I think outside of the office, I have really felt a social responsibility to just being a reliable source of information to our local community. That's taken place over social media, various news segments, and of course, just answering emails, text messages, phone calls from friends and family.
Great, thank you, Dr. Amin. Dr. Ray, Dr. Meyers, you both work in healthcare environments as well. Please tell us a little bit about what your roles are like and what your experiences have been like too. Dr. Ray, I'm going to go to you first.
Sure. So I am an educator at a medical school. It is a health science center, so we do have other graduate students, nursing students, dental, but primarily I've been working with medical students. And, during this time, it's been really, my colleagues and I have been really thinking about how to make sure that our students are prepared to go into the healthcare field, given pandemic, given what we know about racial injustices in medicine. So we've been really thinking about ways that we can strengthen the areas of our curriculum that already address these topics, and then other areas where maybe we need to add more classes or add more other educational avenues. So we've been really thinking about just class preparation, just preparing our students. How do we have these discussions about race? How do we have discussions about social inequities? And how do we have discussions about COVID-19 and what it means to now be a professional healthcare worker during a pandemic for our graduating students? So we've been really doing that. That's really what the crux of being a medical educator right now has just been really about student preparation.
Thank you, and look forward to hearing more of what you have to say about the sort of things and changes in the curriculum and things like that as we go here. But Dr. Meyers, I'm going to go to you next to think about, so say a bit about your role and what your experiences have been like over the last 6 months.
Thanks, Nate. Thanks for including me in this. It's a real treat to be doing this with Drs. Amin and Ray, folks who are clearly making a name for themselves locally and nationally. I've been doing a variety of community-based education in Bakersfield for over 30 years before I fully retired and left town. And one of those activities was back in around 2008 and 9, helping the county task force put together a medical surge plan. And at that time, we focused mainly on disasters, earthquakes, floods, even terrorism, but we were also being told by every epidemiologist, by the way, a pandemic is a certainty. It's going to happen, just a question of how big and when. So we were fortunate that we had a bunch of that prep work already done leading into this, and the County Department of Public Health has done an awesome job of implementing much of the work we did there. My role historically in the hospitals has been to act as an educator and consultant. And I spent those first several months trying to keep up with what was happening nationally and guide local hospitals on, in particular, triage policies, but also what's the best way to treat your employees to make sure they feel safe and that their families will be safe, make sure there's enough protective equipment. And we ended up spending hours upon hours working on triage policies. The consultations in those first months largely dropped off because the hospitals really pared back, expecting huge surges. And again, so we spent most of our time developing, refining, and educating on triage policies. It wasn't until the last couple of months that the consultations have really picked up. A lot of them COVID related because hospitals are doing a much better job of treating folks. We've learned a lot from some of the inadvertent mistakes from New York and New Jersey. So they're able to keep folks alive a lot longer now, and often in a curative way, but often sometimes not. And so it means folks are being kept on critical care much longer than necessary, or maybe much longer than appropriate. Some of whom are unrepresented, they have no family or friends, and so ethics committees have to make decisions about whether to withdraw. And sometimes families are holding out hope in situations where there's clearly no hope that the person will leave the hospital. So the last couple of months have been a lot about that. I would note that all that time we spent on triage policies, retrospectively, and I take full credit guilt for motivating a lot of this, that was probably misguided. We needed triage policies, but it turns out not a single hospital in the United States has actually declared a crisis level. So nobody has had to actually go into full-on triage. In the meantime, we did a cruddy job taking care of our nursing homes, our retirement homes, our prisons, and that's where the real tragedies are emerging. And it's not unusual that ethicists would make these kinds of mistakes. Like most of medicine, we're very reactive. We don't spend enough time worrying about the structural underlying conditions that produce most of these ethics problems. People like Dr. Ray are much more focused on that, and I'm sure she'll be talking about some of those issues tonight. But again, looking back, we could have done a much better job focusing on the things that would have done more to help people than having the perfect triage policy in place that hopefully we'll never have to use.
Maybe just follow up there for a minute before going to the next thing we're going to talk about. So, I mean, if you're thinking that part of the problem was that we were thinking reactively about it. So what does that mean now if we're thinking proactively, looking forward? What are sorts of things that we should be talking about that we're not talking about enough, do you think?
I think we've finally realized, and I'm not sure it was ethicists who figured this out so much as public health and government, that we just have to do a much better job with congregant facilities, whether they be nursing homes or prisons or what have you. California has just had a huge problem in prisons. We really need to be focusing more on how do we get the right kind of separation, the right kind of treatment in those settings, those congregant settings. We also need to be really focusing, I'm sure we'll talk about this more later on, focusing more on how to keep people safe and comfortable at home where necessary, employed, able to pay their rent, able to feed their kids. Ethicists don't spend a lot of time on those kinds of economic structural conditions. And we really, this thing's not going away for at least another half a year. We really need to be focusing more there.
Thank you. To shift gears here a little bit, I do want to talk about one of the main kind of ethical issues related to COVID-19 are the ways in which we've seen inequalities across our society. COVID-19 is impacting all aspects of society, but we have seen that it's having disproportionate impact on some communities over others. Across the nation, we've seen that in Black, Latino, Native American communities who have disproportionately high rates of infection and mortality. And that's something that we've seen here in Kern County too, where recently Kern County's established a Latino COVID-19 task force to look into inequalities in our county and think about what can be done to reduce those inequalities. And to give you just a little bit of data on this before moving into the question about it. So from Kern County Public Health, they don't have data for all the local cases in Kern County, but they have race and ethnicity data for most cases. And for the cases that they do have race and ethnicity information for, 76% of the COVID-19 cases in Kern County are from members of the Latino community. Locally, latest census estimate is that our population is 55% Latino in Kern County. So that's a 20% difference. So thinking about the rates, 76% of the cases that we have race and ethnicity information, whereas 55% of the population is Latino. And on the other side of that, if you think about the white population, non-Hispanic white population in Kern County, that's 33% of the population, but it's only 16% of the cases of thinking about in Kern County of the COVID-19 cases that they have information for. And that's data I looked up at accurate as of today. So Dr. Ray, you're someone who's expert, written a lot about racial disparities in medicine. Can you shed some more light on those disparities of why these disparities are happening?
Sure, and let me apologize, I didn't fully answer your other question. I'll say these past 6 months have been tough. We'll just leave it at that. So when we think about COVID-19, you may have seen lots of headlines or different researchers saying COVID-19 is bringing a lot of inequities to light, right? It's highlighting a lot of racial and social inequities. And although it's a little bit overstated, it's absolutely true. What we're seeing from COVID is really that it was able to thrive because of social inequities created this sort of perfect storm, right? This perfect backdrop. So we have inequities and racial inequities in almost every institution you can think of, in access to transportation, access to education, access to safe housing, which in my research is always the biggest inequity and the biggest social determinant of health, is where you live, who you live with. Do you live near facilities that emit pollution? Do you live in safe neighborhoods? Do you live in neighborhoods that give you access to recreation areas, access to safety, to noise pollution, air pollution? We're also seeing, when we talk a lot about essential workers, we're also seeing some economic inequities. So these inequities, inequalities, in all of these other social institutions created a backdrop for COVID to come in and just create more social inequalities, to further entrench the inequalities that we already have. So what sort of happened with COVID-19 is it magnified these inequities, created more inequities. And so that's really when we look at what COVID-19 is really doing to our Latinx, our Indigenous, and our Black populations. It's just worsening the social inequalities that they already face. So that's one of the things that I think, like Dr. Meyers is saying, is we as ethicists need to spend a little bit more time thinking about how people get to have inequities in health. It doesn't just start in clinical settings. It doesn't just start there, although inequities in medicine contribute to social inequalities, thinking of things like racism and algorithms that we use in our hospital to allocate interventions, provider biases, those kinds of things, just racism in medicine in our medical and healthcare institutions, those do exacerbate the problem. But inequities don't start once a patient enters a clinical setting. The inequities that they experience outside the clinical setting can sometimes put them in a clinical setting and put them in the hospital. So my research has been, especially right now, and one of the reasons why it's just been really tough right now with research is we have to look at the inequities a little bit deeper than just what COVID-19 is doing to our people of color populations, but look at how they ended up in these dire situations. So right now, it's been a lot.
Thank you, sharing some of those aspects about this. And I think, thinking about one term you mentioned is the social determinants of health, and thinking about how social environments impact health. Would you just say a little bit more about that? I think that kind of idea of how these social things are a health issue is an important aspect of what you're talking about here.
Absolutely. So a lot of our health is determined by social determinants of health, right? So thinking one of the ones that I've listed is housing, also thinking about pollution, access to clean air and clean water. We have lots of communities in America who are disproportionately experiencing air pollution and water pollution. You can think of communities like Flint, Michigan. You can think of communities like Louisiana, Mississippi, even some of the poorer communities in my where I live in Houston, Texas. And really what we call it is environmental racism, because disproportionately communities of color, indigenous people, Latinx people, and Black people are the disproportionate bearers of air pollution, water pollution, even noise pollution, which we know have effects on health. So another big thing, of course, is housing, where you live. When we talk about COVID and we send people home to heal, we have to think about their environment. Do they have the ability to self-isolate? Do they have access to clean air, clean water? Do they have access to medicines? Are there neighborhoods near pharmacies and grocery stores where they can get the things that they need? We sort of take it for granted that there's a grocery store or pharmacy in every corner. And for some communities, it's really difficult. They don't have access to these things. They don't have access to transportation. They don't have access to even doctors, thinking about rural communities. So thinking about inequities, of course, for COVID have to begin before someone is infected or diagnosed with COVID-19.
Thank you. And maybe thinking about what our response has been like as a society of this pandemic, and could you say a bit about what you think we could be doing better to address some of the inequities when we're thinking about how we're responding to this pandemic?
Sure. I think a little bit of what Dr. Meyers is saying is very true in this reactionary, right? We've been hit by the pandemic and we said, okay, now let's look at the numbers. Let's look at the Latinx and the indigenous communities and the Black communities. Let's now say they have higher rates of infection, higher rates of deaths, and then also we have lower rates of access to testing. So then it became, okay, now how did this happen? But if we had, been listening to bioethicists and public health officials and sociologists and, all of the researchers who are saying, hey, look at all these inequities that are happening even before a pandemic was even, on the news or anything, if we had talked about and sort of attacking these inequities that happened in these other institutions before the pandemic came, this would be different. And so if we look at our response to it, it is very reactionary, because now we're scrambling saying, how do we change the disproportionate death and infection rates of COVID given this backdrop of social and racial inequities? And so we're really working backwards. And so I hope that pandemic is a lesson that let's look at all these other inequities, and then now let's say, how do we solve these problems? So when the next pandemic comes, we're not scrambling and looking at these disproportionate race for our racial groups.
Maybe one last question on this topic, Dr. Ray. So I know we have a lot of healthcare professionals, future healthcare professionals, and I know this is a systemic issue, but people are thinking and wondering about what they can do at the individual level, and maybe that's part of what you were talking about with medical education. For instance, I got a question before this from a CSUB nursing student asking, well, what can we do about things about inequities like this at the nursing level?
Sure. So one thing, first speaking to medical educators, I think that we have to prepare ourselves to teach issues of race, gender, social inequity, social determinants of health. If we aren't skilled and we aren't able to have these conversations, and sometimes difficult conversations to have with ourselves and then to have with our students, then we can't do anything about the situation. So first, I think faculty, teaching faculty have to be prepared to educate the next generation of healthcare professionals. But if you're already practicing, I've been giving a lot of lectures lately to pediatric fellows and just psych fellows and just different healthcare professionals, because I think which I'm really excited about is that people want to do things differently. People are excited and saying, what can I do to better this situation? And one thing that I always say is you have to first interrogate your own biases. Everyone has racial biases. Just because you put on the white coat does not mean that your racial biases stop, right? So it's an interrogation of your own racial biases, asking yourself questions like, how do these biases affect my patient's care? How can I interrogate the racial biases of my institutions? How can I be an advocate for my patients? But then also thinking about your research, right? Are you including people of color in your own research? Does your research have racial biases? So I think it first has to start with an education of ourselves, an interrogation of ourselves, and an admittance that if we are practicing in medicine, we are a part of the problem, and that we are the ones that have to change it. But it first starts with our individual selves. It first starts with questioning our institutions. It first starts with questioning our policies. And especially if you are senior faculty, you are a senior practicing any kind of health professional, you have that security. I think that you really have to set the example. You really have to take the lead, and then students or more junior people can follow. But I think it starts with ourselves and our institutions, and you can start at a small scale and do really, really big changes for the community of medicine and for people of color.
Thank you. I want to shift gears a little bit here and think about more of kind of questions that individuals are facing, of the kind of choices that they're making in their own lives, or the choices they're making for their families. And I want to preface this by saying that many people are struggling right now, of thinking whether that's economically due to lost income or a lost job, parents that are trying to figure out how to manage virtual learning. That's something we're doing in my house now, of thinking about how to make that work, and thinking about how do you make choices with kind of your family and yourself in mind. So Dr. Amin, I want to ask you a few questions related to this. And I always think about the question with families here about it. I know, thinking about, you're trying to manage different things as a parent. You're thinking about, I need to keep my kids safe. I need to keep my family safe. But I'm also concerned about their social needs. I'm concerned about their educational needs right now. So if you could speak a little bit about what are the kind of things you're hearing from families, and what kind of advice are you giving to them right now?
Well, I think it is exactly as you stated. Our families are worried not only about this pandemic, but given how long it's going on, what are the impacts that is this pandemic creating in our children who are not socializing for months on end, who haven't been inside of a real school, for parents who are struggling emotionally as well, just bearing all of these responsibilities on their own shoulders. And I personally have told a lot of them that this is a marathon. It is not going to be a sprint. It wasn't going to be a sprint in March. Just as my colleagues have said, we are several months away from moving out of this. And I am a proponent of creating a quarantine where one family chooses one other family, perhaps two at the most, that have a similar viewpoint when it comes to this pandemic, social distancing, mask wearing, and allowing the families to engage with one another. Let the younger kids play, let the teens hang out, let the adults have that adult time to talk to each other, because that is so important for our mental health. And physical health and mental health are what are going to get us through these next few months, and it's important to pay attention to both of them. I've also reiterated to them that very early on, the message was stay home, stay home, stay home. And many people took a very literal meaning to this and did not leave the confines of their home. And this can also be quite detrimental to one's physical and mental health. And so this pandemic does not mean stay home in your house and live in fear. It is okay to go outside, minus the fires and the heat and the poor air quality at times that we have been struggling with. But it is okay to emerge from your home. It's okay to go outside, to take a walk, to explore nature, to go and do something different. You just need to maintain your distance and wear your mask.
Thank you. So I think that's helpful advice. Me thinking about for my own life here too. And so it sounds like you're saying that a big part of this is a kind of balance. So you're thinking about, like you mentioned, like you should be trying to do some things, think about physical health, mental health, but with taking reasonable precautions. So are you also thinking about the kind of limits of that, of the, like you said, wearing a mask and other sorts of things? But if families are wondering, or parents are wondering, well, can I go do this? Or should, a lot right now are thinking about schooling, and is it okay for kids to be thinking about, or when would it be okay for kids to be doing kind of things that are more in person?
Mm-hmm. And I think a lot of the children's activities depend specifically on the activity as well as the responsibility that the organization is taking. So some sports have resumed with at least practice. These kids are practicing outdoors. They are 6 feet away from each other. The coaches are wearing masks. The parents are not allowed to congregate in close quarters around the practice, and there isn't very close physical contact amongst the children. And I think that if you are willing to take that level of responsibility and adjust from what is your normal, it's okay to give these kids a little bit of a life again. What really pains me is that we have this virus that does not have a strong predilection for children, and yet our children are the ones who may very well have the longest impacts of this virus if we don't start to make some adjustments for their well-being.
Thank you. So I want to ask you a question like I asked Dr. Ray for the healthcare professionals tuning in, or future healthcare professionals. And I think a lot of people thinking about several of the things you said about communication. So how do you communicate with families, or do you have tips to offer people there's a lot of misinformation out there about the pandemic, and how do you get across accurate information, or what kind of tips might you give a healthcare provider that's thinking about how do I communicate?
I have found that the best way to communicate, particularly with my patients and their families, is to let them ask questions, let them guide the conversation. Rather than me just endlessly talking about what I think is important, I want to know what they're feeling, what they're experiencing, and then being able to use my knowledge base and my experience to guide them in the direction. And if they're struggling with making a decision, to delve further into that. Are they struggling because they are emotionally hurting and they're not providing themselves with something that they really want or need? Or are they struggling because they're feeling pressure from other friends or family to do something that doesn't necessarily sit well with them at this point in time? And so it's really going back to those medical school basics of open-ended questions that you start with, because they really will reveal to you what your patient wants to know from you and what you can provide to them.
Thank you. Okay, I want to step a little more broadly from thinking about kids specifically, but think about other kind of choices too that I know people are weighing. It's like we're all now risk-benefit calculators of thinking about what is it that I can do safely and what is it that goes too far. And people are trying to think about, well, yeah, like you said, we're 6 months into this, and what are kind of steps that I can take that are safe and that fit with things that I can do. So, let's go back to Dr. Meyers here first, of thinking about, if we're thinking about people and people that are weighing kind of values that they might have here of, whether that's considering whether I should support a local business or go visit a family member that I have. What are a couple values or things you think people should be keeping in mind when making those kind of decisions?
Ironically, coincidentally, about an hour ago, my niece called me. I made the mistake. She gave birth to a very premature child, and I gave her reasonably good medical and sort of ethics advice. So now every time she has an ethics question, I get called, and I hate it because they're always that kind of question, Nate. I think these are just extraordinarily difficult questions. An hour ago, she called to ask me whether she and her brother should fly from Seattle down to Los Angeles to visit my mother, who's alone in a retirement facility and hasn't had family visit, in fact, since my stepfather, her husband, died a few months ago. And my response was, that's an extraordinarily generous but probably stupid decision. I think she and her brother are healthy enough that they could do that and probably get through it okay. But they're flying on an airplane, they're renting a car, they're dealing with airports. And how easy would it be for them to pick up a virus and carry it into a facility that's a combination of memory care and nursing home and retirement, independent living. My general take is that we should be as conservative as possible, because probably the most vital ethical principle, at least here, is try not to harm other folks. And as we were talking before, just as all of the changes for how you folks are doing teaching these days are definite reductions from quality, they're still pretty good. You're still doing a terrific job of engaging with your students and trying to figure out how to make sense of all of this stuff. As inadequate as they are, Zoom meetings with families, regular phone calls, all of the different ways that we can connect while still being as safe as possible, I think for now at least are still the way to go. I love Dr. Amin's suggestion of sort of pod groups. Figure out folks that you can be safe with and do what you can to connect with them. If we lived next door to my mom, I'd be visiting her every other day. But for me, it would mean an 8-hour drive, having to stay in hotels, risking all of the things that are associated with that. Last thing I'd want to do, God forbid, is carry a virus into that facility. On the broader question about beyond families, the economic impact of this is going to be devastating. We're already in a recession and it's going to get much worse. So anything we can do, those of us who have the means to help our local communities, whether it's through donations or just getting takeout. One of the reasons my wife likes to travel is she likes to stay at hotels to get room service. That for her is like the epitome of luxury. Well, we now treat takeout as room service. There are lots of easy, safe ways to do that. It's fun. You tip like crazy. Give people as much of a tip as you can because they're all struggling too. Again, those of us who have the means to do it. Trying our very best to both not harm people, non-maleficence, and do what we can to help people, beneficence. For me, those right now are the two most critical ethical values we should be focusing on.
Thank you. I want to pause here too and remind the audience that we can send in Q&A questions that we'll answer here in just a little bit at any time. So if there's other things you want to hear me ask about, you can use that Q&A function to do that. I feel like my experience is a little bit like Dr. Meyers, that if you're someone who teaches ethics, you get all these questions from people, then you're thinking about how am I going to answer, how to weigh these things. And I think you've given us some good principles to think about harm, avoiding harm to other people and sorts of things like that. Dr. Ray, I'm guessing you get these kind of questions too. And do you have things that you would say to people?
Sure. I think it's also funny. I talk to my students and they're in this weird situation because they're fourth-year medical students. And so their families ask them questions, what should I do during a pandemic? But at the same time, they're fourth-year medical students. So their family says, well, you're just a medical student. I don't listen to you, right? So I feel for them that they're in this weird limbo phase. But I get asked kinds of questions too. I especially get asked questions about people of color who are extra fearful about going out because they're fearful of what will happen to them if they do get infected and have to go into the hospital. They're concerned about will they be treated fairly. So they have extra concerns about not getting COVID, or if they get COVID, can they try to get better on their own at home because they feel safer at home because they're more fearful of going to the hospital and what can happen there. So my questions are a little bit more race focused, and they tend to be more out of fear of being mistreated by medical personnel. So I kind of, Dr. Amin, I kind of do the same things that she says personally and kind of recommend is find people with values the same way you do and create your pods. I do that. We also try to do things outdoors. If I do meet a friend who has also been social distancing and wearing a mask, we'll meet outside on a patio, on the restaurant patio, not indoors where people are wearing masks and those kinds of things. So we still try to support local businesses through takeout or patio seating, but we do follow our mask and washing hands and social distancing. But I found that it's easier because like you said, mental health, like Dr. Amin said, mental health is also something that we have to think about, especially with people who don't have families, or with the elderly, or with the geographically isolated. So yeah, that's what I do, and that's what I always recommend. But yes, the kinds of questions I get as an ethicist are usually much more about people of color just being afraid of medicine, and particularly afraid of what medicine, how they will be treated during COVID, and also very fearful of the vaccination, and bringing up past fears of racial abuses in medicine.
Dr. Ray, I had gotten another question from a CCB nursing student that was on that topic of thinking about lack of trust in the medical system due to historical, individual, systemic reasons for that, and that thinking about now, what do you believe are effective interventions? So this is, as the CCB nursing student put it, what do you think would be effective interventions in our community, as well as individuals, to promote confidence in health services in underserved populations?
Sure. So first, I think what we've been missing from medicine to repair the relationship between Latinx, Indigenous, and Black people and medicine is an acknowledgement, first off, of past abuses, and an acknowledgement that there are certain abuses, maybe not as atrocious, but still deadly, that they're still happening, right? So we have certain institutions who have acknowledged their history with male circumcision, and they have acknowledged their abuses in that regard. And I think medicine, and with their regards to race, have to do something very similar. This acknowledgement of, yes, we did this. Yes, we were complicit in this. Yes, our healthcare system is based on racism. This is now how we're going to make amends. And here are these very concrete examples of the ways that we are going to change our practices, change the way we educate providers to make amends. So I think we're still lacking that. We're still lacking an acknowledgement, because I do a lot of lectures to healthcare professionals, and there's always someone that says, my favorite line, I treat all my patients the same, or that was in the past, Tuskegee happened so many decades ago. But we have research that just came out in 2020 and in 2019 that says the legacy of these historical abuses still affect the relationship between people of color now. When we talk about sterilization of Indigenous people, that still affects the way Indigenous people think about medicine now. So these historical abuses, one, they still matter, but also there are current abuses happening every day. So it's not always just this historical thing. So I think first, just an acknowledgement, and then a concrete examples of policy changes and education changes, and how it's going to be addressed going forward.
Thank you. I'm going to go to the list of questions now that we're getting here. We've got a good list of questions from participants. So again, you can keep sending these in. We've got some good ones here. One thing that you talked about, Dr. Amin, before, was thinking about how to try to find people who share the values that you do, and think about ways in which those might be people you're more comfortable with interacting with. But we have one question from an anonymous attendee here who says, well, what about people who don't believe the same thing that you do? How should we respond to people who don't believe in the virus or go around without respecting the rules?
It's certainly a challenge, no doubt. What I have found, as I have sort of put my face and my opinions out there, is that if you treat those individuals initially with respect and create a dialogue with them, asking, why do you feel this way? Why do you act this way? As opposed to just blasting people the way that some feel like they can on social media or behind a screen, can often help. Sometimes these are your good friends, or they're your family members who feel differently than you about this pandemic or social distancing or mask wearing. And it's okay to have that talk. It's okay to have different opinions. And I think that dialogue helps so much to clarify and prevent us from just digging our heels into the ground. Then you tend to have that group that, you know, pokes fun at people who are wearing masks, or really just outright degrades people, make them feel bad for worrying about this virus. And that, of course, is not appropriate. But to me, I think you lead by example. You know, you do what feels right to you. If you believe that this virus is real, that it really has killed almost 200,000 people in the US, that we need to social distance, that we need to wear our masks so that we can start to move on with our lives, then you do that and you let people see that, and don't let others affect you in that type of opinion.
Thank you. Dr. Meyers or Dr. Ray, would you like to talk about that issue too, of how to talk with people who have different views than you do?
Yeah, I think sometimes it can be just about action, right? So there a few articles have come out from psychologists about how people, of course, want to be in the in-group. People don't want to do things that set themselves apart or that look different, right? We've all been to middle school. We remember not wanting to stand out from the crowd, right? So I think masking can be very similar. I think sometimes it's just leading by example, right? Not if you wear a mask, maybe others will. And we have research now, very preliminary, shows if you just start doing it, if you're sitting around with friends and you wear a mask, then they're more likely to wear a mask as well. So I think sometimes leading by example can be helpful.
Right now, I'm mostly living in a ski resort town in Eastern Sierra, and all the locals are great. I mean, even out on trails, folks are wearing masks. Folks are stepping off trails to get out of everybody else's way. You can't go into the grocery store and run into a local who's not wearing a mask. But we've just been horribly inundated with people trying to escape urban areas, particularly Los Angeles. And those folks, you know, it's sort of like the when you're in Vegas syndrome. They kind of feel like the rules have all changed once they get up here. And we had massive spikes right in March when everybody came up to ski. And then we had another massive spike after the 4th of July. And the temptation is, I think as Dr. Amin, both Amin and Ray suggested, you just want to scream at people. And we also know that some of these people get pretty testy when you do that. There's a story that an out-of-towner pulled a gun on somebody at our local grocery store who asked them to put on a mask. So I think the general attitude is this has become such a politicized issue with so much misinformation about it and a kind of tribalism attached to it. In the kind of interactions that I'm talking about here, you're not going to change anybody's mind. The best you can do is get away from them. Try to protect yourself as much as possible. Try to protect your family from picking up something and carrying it to them. And then do everything you can generally to educate folks. It's just a horrible shame that it has become politicized in this way. It's just a public health issue. The virus is going to get you, whether you're a supporter of this presidential candidate or that one. We're not, but for some of these folks, nothing we can do is going to make a difference. So the best we can do is protect ourselves and our loved ones.
So we're talking about masks here a bit, and I see one question about masks. So maybe Dr. Amin, I'm going to pose this one to you. So this is someone who's writing, one of the attendees tonight, writing that some people, they've heard from people that wearing a mask doesn't make a difference. Other people say it is important to wear a mask. And can you say a little bit more? What's the purpose? Why should people be wearing masks?
Well, I certainly don't blame people for being confused, because from the beginning, there's been mixed messages about masks. But what I can say is that masks do absolutely decrease the spread of COVID-19. I know you've seen memes with the cutout of the side of the box that says that it doesn't. These are written by the attorneys for these companies for reasons far different than controlling the pandemic. They will prevent you from sharing your saliva and your respiratory droplets and your nasal droplets, and they will decrease the spread. And the most recent literature is saying that it decreases the spread on the order of 6-fold. And we need to wear them because it is going to help us move on with this. I think there have been several who say that masks are dangerous. And I always bring it back to our surgeons. Who in this earth would have a surgery done by a surgeon who would not wear a mask during the surgery? Nobody. The reason they wear it is to prevent their saliva from dropping into the surgical cavity. And they've been doing this since the 19th century. And there is no evidence that surgeons live lesser of a life than the rest of us because they spend 8, 10, 12, sometimes 18 hours in a mask. Now, every single healthcare provider that you see is spending 8 hours in a mask, and we're all doing okay. So it is important to wear your mask. It is going to help us move on with this. They absolutely work, and they do not harm you when worn appropriately.
Thank you for that very clear information here too for our attendees. There's one question here from listed here as a third-year medical student who's attending the event tonight and has observed about how some faculty, fellows, or residents who are not following appropriate guidelines of social distancing or masking outside of work, but maybe even in the break room. And they're thinking about what kind of advice could you give to someone how to handle something like that while respecting the educational hierarchy for a third-year medical student. So maybe Dr. Ray, do you have advice for this attendee?
Sure. So I get this a lot from my medical students about how to respect the hierarchy and how to frankly protect their careers when they see misconduct from their superiors, from their attending. You know, when you're a medical student, you're in a very precarious situation. You want to get the benefits of being liked and doing a good job, but then at the same time, you have to respect the boundaries and respect your position. So I'll be honest, this is very tough, because like the attendee said, you want to respect the hierarchy. So again, I am always a lead by example. Like I said, with the mask situation, I would just start wearing a mask, right? In the break room, when we're talking, I would social distance. If we're talking and the person gets too close, I would take a step back and say, oh, I'm just social distancing. I do think that you have to be prepared because there are going to be comments. I think that's probably likely. But I always say, if you can lead by example, just wear the mask. Even if you're in the break room and no one else is wearing a mask, if you feel that way, wear a mask. If you can go somewhere else, go somewhere else. Someone asks you why you aren't in the break room, be very honest. I'm not there because people are not respecting the pandemic. People aren't wearing masks. I feel more comfortable if people wear masks. And again, I'm not downplaying how much of a precarious situation this medical student is in. I certainly hear this from my students a lot, but that's what the advice that I always tell my students is, if you do it, maybe others will follow.
Nate, can I jump in on that just briefly too? I've long thought that one of the more important roles that a hospital ethicist can play is as a power equalizer. Hospitals are very hierarchical institutions, and it's not just third or fourth year medical students, but even within attending ranks. And that's one of the things that an ethicist can do, assuming that we have sufficient independence within the organization and the willingness and comfort zone in challenging folks. Whenever there's that kind of power differential, go talk to the ethicist. And if she or he believes it's an issue worthy of carrying forward, they can probably do it in a way, hopefully they've established a kind of respect-based rapport with the hospital attending physicians. They can do it in a way that makes it a positive, let's role model this, as Dr. Ray was saying, rather than put the medical student or first year resident into a bind and then work together to solve the problem.
Thanks. Dr. Meyers, I'm going to go back to you here. There's another hospital ethics question, and this is a different ethical issue people have been concerned about, is limitations on family visiting patients who are in the hospital and how that causes very difficult situations for many people, for both patients and their families. And the person who sent in the question mentioned about how we have patients who are very sick, some on comfort care, family members who have asked to sit with the patient, but that's against the hospital policy, and a nurse having to ask for a higher level of management for family members to be with the patient. So would you shed a little light or think a little more about how hospitals should be thinking about, or what you might say to people struggling with this kind of issue?
Once again, I think it's tremendously difficult. My sense is the hospitals do right by, as much as possible, keeping families safe and keeping the rest of the hospital environment safe, staff, and of course all the other patients. My understanding is that all of the hospitals in Bakersfield, all of the ones that I work with, do have exceptions for patients on comfort care or end-of-life protocols. They do allow family visits. If they're being told otherwise, if it's one of the hospitals I work at, give me a call. If it's Mercy, any of the Mercies or Memorial, you could call Nate, who works at Memorial, but talk with the clergy staff to get clarity on what the policy is, and make sure that family can be there with somebody in their dying moments. Again, when my stepfather died, he was in memory care. We knew we were not going to be there, so we hired somebody to sit with him. We knew we couldn't be there. It was, again, April, right in the midst of all of it. We wanted to make sure that he wasn't alone, so we hired someone. Sorry. Because that's just, there should not be anyone who has to die alone. And if the hospital can make it work by allowing family in, or by doing something like taking someone that the patient is familiar with, by all means, hospitals should do everything possible to make that happen.
Thank you, Dr. Meyers, and sharing that story as well here, thinking about that, this is a really important issue. Is this something that Dr. Ray, Dr. Amin, that you'd like to address as well?
Sure. One thing that I think about is, again, since my research is on racial disparities in health, thinking about racial disparities that happen in the hospital setting, I do think for people of color that it's very important to, for hospitals to try and to allow someone to be there. Too many times, especially if a patient is incapacitated, they need a family member or a friend that can be an advocate. Not saying that all patients don't, but because of the disparities and because of the mistreatment of people of color, it becomes very, very important, right? We have research that tells us just how necessary it is to have someone there that can speak on their behalf, that can press the faculty if they see, the staff if they see something wrong. So, other than just comfort, which obviously everyone should be able to have someone at their bedside when they're suffering this terrible virus, but it's also important to have someone there to be an advocate. So that's how I think about having someone next to their bedside.
Yeah, I agree wholeheartedly. Being hospitalized is an experience like no other, and you need someone there. I recently went through a bout with my father, who was hospitalized for a few days back in June, and my brother and I were by his side the entire time. And quite honestly, I can't imagine how someone who can be so sick in the hospital could get all of their basic needs met without having an advocate there. And particularly when you have someone who is close to death and their family wants to visit them. I understand when we were at the beginning of this thing and we didn't have enough PPE and we didn't know what we were dealing with and we didn't know how contagious it was and so on and so forth, it might have been a little bit different. But we all have masks now. we should be able to be with our loved ones as they are passing. And I do think that hospital administrators are starting to see the importance of that. I had a good friend from medical school whose mother unfortunately died of COVID-19, and she essentially started a petition, and ultimately the hospital administrator let her be with her mother in those last few moments. And that was back in May, I believe.
Dr. Amin, there's another question here for you from one of the attendees, and this one, they specifically addressed it to you of thinking about, so the question is, how do you take care of an elderly grandparent who does not believe in COVID, even though they got COVID? And that this grandparent has Alzheimer's is another factor here of thinking about it. So what would you give advice to this attendee?
Well, it's certainly going to be a challenge, but I think that your primary focus in taking care of that individual is to not give them COVID. And since they've already had COVID, perhaps that's somewhat of a moot point. But it doesn't mean that you don't wear your mask while you take care of them. The purpose of the mask is to allow us to be within 6 feet of other people when there is a chance that we're going to share our saliva or our respiratory droplets. And if you're caring for someone who's elderly, obviously you're going to be in close physical contact with them. So you wear your mask and you do your diligence to take care of them. They may not fully understand, they may not remember, they may not care, but that's okay. You need to do your due diligence in taking care of them. And quite honestly, if they've already had it, it wouldn't be a bad idea for you to purchase an N95, which are available to you through some pharmacies here in town, so that when you're in close contact, if they're not wearing the mask, you also can be protected.
Thank you. There's a related question here too. I think you're partly addressing it there, but from Esmeralda Robles, who asks, how can you care for someone with the virus without infecting yourself?
Well, if it's a household contact, to be quite honest, more than likely you have already had a very significant exposure and you may have already been infected. You might be asymptomatic or just have mild symptoms, but very often the household contacts have already contracted the virus by the time that the individual who is positive is going to get the test. If you have been negative, then there are a few different things that you can do. One, you don't necessarily need to isolate this person to the dungeon of your house, but when you guys are having meals together, maybe just spread out throughout maybe the dining room and the kitchen so that not everybody is eating right from the same table. The same thing if you're watching television together, spread out across the living room. If the weather and the air permits, open the windows so that there's more circulation going in and out of the house as well. And if it suits your family, wear your masks inside until that individual has finished his quarantine, just to keep everybody safe.
Thank you. I'm going to keep going here. We have a bunch of questions in our queue. This one is for you, Dr. Ray, from Brian Russell at Bakersfield College. And he's wondering about disparities that we see in infection rates and how much of those disparities or what evidence has there been about how much of that is due to economic disparities as opposed to other factors like racial factors or things like that?
So, that's a difficult question to ask because it's a question about tell me that racism exists, right? I mean, that's essentially, tell me that we already know that there's information about racial wealth gap, right? We already know that the average family is about almost double that. So there hasn't, for COVID, I can't say that there's a research that says this is the income of the Black people who are infected and talk about rates. There certainly has not been that. There's been a lot of lacking in racial information about COVID. As you said, as Nate said at the beginning, of the people who have been tested in this small sample, we can talk about the race makeup. But race data hasn't been released and hasn't actually been taken for a lot of people who were early diagnosed with COVID and early on in the pandemic and who died. So really, it's more of a how can it not be related, right? If you think about what wealth controls, think about what your income controls. It controls where you live. We already have the data that says your zip code tells us so much about your health, right? So it's kind of like, we'll see here is a connection. We already have information about where you live, who you live with can affect your health. And now we're in a pandemic. So again, how can housing not? So we don't have the exact data. No, I can't say that, but we know racism exists. We know racism exists in medicine. We know that inequities, social inequities exist. We know the power and strength of social determinants of health, and we know there are inequities and social determinants of health. So it's sort of a connecting the dots kind of situation. Perhaps there'll be more information coming out about these connections, but right now it's like, well, we have A, we have B, we can therefore deduce C.
Thank you. I should say one other aspect of his question here is, part of the question was, would we be able to address or deal with these inequities without dealing with the wealth gap in our country?
Absolutely not. So the way that I approach racial disparities in health, like I've said, is addressing racial disparities in other institutions. And one of those has to be economic inequality. So I think we have to address the wealth gap to address lots of other things like racial disparities in health, racial disparities in education, disparities in literacy, disparities in access to clean water, clean air. So from my perspective, we have to address things like the wealth gap before you can address inequities in COVID deaths and infections.
Thank you. Okay, one other question we have, and I think a couple questions related to this. Now, something been increasingly more in the news, and hopefully we get more positive news about vaccines in the news coming up. The one question that we have here of thinking about from Dr. Jim Garb is, can the panelists discuss issues involved in prioritizing a vaccine? Dr. Meyers, would you like to say a few things about that?
Yeah, so fortunately, again, there's been quite a bit of prep work on this question because, again, we've known that a pandemic was coming, and so folks have done quite a bit of good research in policy development. The general consensus is that it goes to first responders first. And unfortunately, given the way that this vaccine will likely roll out, there's an urgent need, and it's going to take quite a while to get enough doses produced and distributed to be able to go widespread. The current thinking is that all of the first round of doses will go to first responders, in part because even saying first responders is too ambiguous. Of course, we mean emergency room physicians, infectious disease specialists, intensive care physicians, respiratory therapists, respiratory physicians, but we also need the food services staff at hospitals. We certainly need the janitorial staff. We need IT. If the computers go down at any hospital across the country tomorrow, that hospital shuts down. Everything is electronic medical record now. Accessing therapeutic interventions is done electronically. So you start building up that list. You add police and fire and EMT, and folks are talking about Uber and Lyft drivers because many of the patients won't be able to get from home to hospitals, going back to some of Dr. Ray's concerns. Before you know it, we've used up the whole first round. If we're able to spread it out enough, or when the next round of doses becomes available, let me back up just a sec. By saying that it goes to healthcare professionals first, we also have to be distinguishing among those. Not all healthcare professionals are frontline workers in COVID. Obviously, some of those physicians and nurses I just referenced are, but maybe not the oncologists or the neurologists. And then once we get past that first layer, we can expand it out to other healthcare professionals who can also fill in as needed and continue to do all the other important medical work. But then I think that, again, the general consensus is, unlike with the ventilator distribution, these should go to the most vulnerable. So thinking about nursing homes, the staff in particular, but also the residents or patients there. And then folks are also talking about children being next on the list. So almost a kind of reversal of what we've been thinking about with triage policies for critical care. But either way, we got to get those things out there first, and we have to get enough good education, good emphasis for people to actually take it. It won't do us any good if 25% of the population are the only ones who are willing to step up and take it. We got to get to 70, 75%. Again, education, trusting science, and an associated thing. I hope folks are getting their flu shots in coming weeks, because when those two come together, it's going to get really messy.
Thank you. Yeah, we have another question related to just what you were talking about. And Gorman asks here, could the panel talk about giving advice to patients regarding expected vaccines, and particularly fears of being in the early adopter group for a vaccine? Dr. Amin, do you want to take that question?
Absolutely. So I think a lot of the fear that has been related to this vaccine is how much it has been present in the news, and how much funding has been going to these companies, and how there is this great race, if you will, amongst the companies to come out with a vaccine. And from the general public, we don't want our vaccines to be in a race with one another. We want the science to be tried and true, and we want to know that a vaccine is going to be effective, but it's not going to hurt us. And so I think that fear that is coming around about this particular vaccine is understandable. But I do think that the companies right now are holding true to the fact that they are not going to release a vaccine to you unless it is safe and it is effective. And I'm sure you've heard just as recently as yesterday that one of these companies put their trial on hold because of an adverse reaction. And quite honestly, that shouldn't scare you. That should reassure you that the process is working and that scientists are adhering to the process. They are not succumbing to political pressures or financial pressures. What will come to you ultimately is a vaccine that will be tested in literally tens of thousands of individuals, and it will be determined as safe. And if we can't get to that point, then it's not going to reach you.
Thank you. One more question here about vaccines from participants is, how can we be sure that the distribution of vaccines is going to be equitable? How do we make sure that people in lower income communities have the same access to people in other groups? So I don't know if any of you want to take a shot at that question.
I'll take a shot. So this is also another question that I get when I do interviews or from people of color. I think what it's going to take is advocacy. So this is also related to a question earlier about that you asked, what can I do as a healthcare professional to change this relationship between the economic vulnerable, the racially vulnerable. And I think this is one of those ways that people can be an advocate to help and make sure that, that they make noise and that they speak up about an equitable distribution. But I think it's going to take advocacy, and I think that it's going to take advocacy from healthcare professionals and from ethicists to sort of make some noise about it.
It'll also take good work from the public health departments, because they will be doing a lot of the rolling out of this. And Bakersfield is very fortunate to have some terrific leadership in their public health. Other communities have struggled in part because so many of the public health professionals have taken so much criticism. Many of them have had to quit or retire because they actually receive physical threats. But they can make a huge difference here. Some of the treatment medications like remdesivir when it was rolled out, at least in California, the distribution was made based upon most critical need. And so the state gave some doses to public health. Public health then doled it out to the hospitals based upon where it would do the most good. My guess is something like that will happen with the vaccine as well. And if you have right kind of committed folks in your public health department, some of those inequities will be nipped in the bud from the outset, one would hope.
Thank you. We have about 15 minutes left of our conversation tonight. For those of you who get or need or going to get CME or CEU credit, I remind you there's a link to complete to do that. That's in the chat for tonight's conversation. But I want to make sure I get to some more of these questions here too. We've got a lot of really great questions coming in. On a different kind of group of questions here, there's a few questions about education. So there's one question from Deborah Jackson about, it says, many parents are eager for their children to return to classrooms. What needs to be in place for this to be safe? How would you advise educational leaders? Dr. Amin, do you want to take that one?
Absolutely. I completely agree. I do feel that the great majority of our children need to be in the classroom, not only for their education, but for their physical, their social, their emotional health. But in order for our kids to be in school, just like we do on so many other levels, we need to make sure that it is safe. Safe for the children, safe for the children's family at home that they come home to, safe for the teachers, the hospitals, the school staff, and the administrators. And we cannot necessarily open the schools if our numbers are rising or are catastrophically high. And I will say for Bakersfield that we are improving, which is a great sign. And I'm hoping that Labor Day weekend does not interfere with the general trend of improving numbers. But we need our numbers to be better so that we are not having so much quote unquote accidental spread being brought into the schools. We need to make sure that schools have the ability to socially distance the kids from one another, both from a physical standpoint in the classrooms as well as from a financial standpoint. And we need to make sure that masks are not an issue of contention within the schools. This means that us as parents have to teach our kids how to wear the masks so that the teachers are not 100% responsible for this. And we have to teach our kids to respect the masks so that the teachers don't spend the entire day telling everyone to keep putting it back on and cover your nose and take it off your chin and so on and so forth. That's what's going to allow our kids back in the classroom. I know it is far from ideal. It's not how we necessarily want our kids in school, but this entire year has been far from ideal. And so we are going to have to adjust in order to get our kids back in school and put their priorities and their needs first.
Thank you. We also have a question here about college education. This comes from Jessie Eisenagel. And so she's asking about colleges, and many colleges have opted to allow students to return with limited in-person classes. This has caused many spikes in college areas. Do you have advice for colleges themselves in advising their students and controlling the spread of the virus, thus further protecting the permanent residents of the area? And I should say too, just today, CSUB has announced that we're going to be online in the spring too. So thinking about as far as colleges go, different colleges have made different decisions about that. So yeah, Dr. Ray, do you want to say something about this issue?
Sure. I think it's very similar to what Dr. Amin said about primary schools. I think some of that advice still applies, is that if we want everything to be safe, of course, it is important to be back in the classroom for various reasons. But of course, we want to do it safely. And so advice, one, I would encourage schools to make it easier for faculty, for staff, and for students to follow the rules, such as wearing masks, social distancing, washing hands, adding in hand washing stations. I've seen that in different grocery stores. I've seen an increase in hand sanitizer. I've seen masks be made available. And using the larger classrooms, but having fewer students. Also doing hybrid. Now, I haven't taught undergrad in a while, in a few years, but I do remember that you can have very large classes and it can be a lot of work just doing your normal teaching. And so I really feel for faculty who have to sort of balance hybrid classes and who have to sort of double their workload to make sure it's safe. And so I encourage colleges administration to take this into account, to do whatever they can to make it easier for faculty, to make sure that they are educating students, but then also doing it very safely, one that protects their health and the students' health, and then the family and friends that they see afterwards. So encouraging schools to take those safety measures and making it easy for people to take those safety measures, I think is very important.
Dr. Amin, would you like to add to that?
Absolutely. I think that, the college dynamic is a difficult one to assess because it's such an exciting time in these young people's lives, and they deserve to go to college and move away from home and live in the dorms and have all of those independent experiences that unfortunately COVID is trying so hard to take away from them. But at the same time, it's also just a brewing ground for this particular virus. College kids don't spread themselves out very well. The dorm and some of these classes of 400 and 500 students is exactly the opposite of what we need right now. And then there's the issue of when these kids do pick up the virus. Do you ask them to isolate in their dorm room when they don't necessarily have anyone else to help take care of them? Do you then send them back to their original community because the home communities don't want them either? And so these are very difficult questions to ask, and particularly putting an 18-year-old adult, but recently child, into this situation can be very difficult. And so I feel for them because I know they want these experiences, but I also believe that these experiences will be there for them in the future, and that right now, online classes is probably the better way to go.
Thank you. A different question here. Dr. Meyers, earlier you brought up issues about different types of facilities, including prisons is one that you mentioned. And we have a question from Yoselin, who identifies as a community organizer who advocates for the lives of those who are in prison. And she says, do you think it's ethical for people to be in prison during a pandemic? What do you think of the Free Them All campaign, if you've heard of it?
I've not heard of the Free Them All, but obviously California has released a lot of low-level offenders, nonviolent offenders, much to the chagrin of folks like the Kern County Sheriff. I don't have a problem with keeping folks in facilities where there's the potential for crowding. We just have to spend the money to do it right. You can't have two inmates in the same cell together. You can't have large gatherings at meal times. If you're doing outside exercise, you make sure you just insist that folks are wearing masks. You engage in all the same kinds of healthy practices that we would want to do for schools or universities. We have to do the same things for prisons. Part of the just almost unmanageable problem right now is that we've been such a incarceration happy society for the last several decades that our prisons are already overcrowded. So the only way that folks like Governor Newsom had to at least begin to address that problem was to release some of them, and that creates conflict in the community. But it's just going to have to be that continuing, ongoing balance. It's completely, of course, unjust to sentence a low-level offender to a potential death sentence by putting them into a COVID-rich environment when otherwise they might get out in 6 months to a year. One of the other mistakes California made was they transferred patients from facilities in which COVID was raging and sent them to other prisons and hadn't done proper testing. And so, of course, now those other prisons quickly got infected and were spreading it like wildfire throughout their facilities. Obviously, they have to do much more aggressive testing. In the end, with so many of these things, it's going to take good, smart, creative thinking, but it's also just going to take a lot of money. to do the kinds of things that we need to do in elementary, secondary, and post-secondary education, you have to get people apart. And smaller class sizes. You can't have lecture halls with 600 students in them. If you're going to do in-person teaching, they have to be small. If you're going to incarcerate folks, you have to figure out how much money you need to spend to keep them separate from one another, so you don't just have it raging through that community.
Okay, we have a couple more questions here I want to make sure get to as well. This one is from Diana Rios, and she has a question for Dr. Ray. She says, I'm a CSUB alumni, now a pharmacy student at West Coast University. What advice do you have on how I could advocate even more for areas with limited access to community pharmacies that's based on racial segregations? What actions can we take now?
So yeah, so that's a tough one. So to give an example, I know of a community who didn't have gas stations. It was a racially segregated neighborhood, and again, we take it for granted gas stations on every corner, but there also weren't any grocery stores. So actually one of the very large gas station companies, people lobbied, people contacted them, and they eventually built one in this very rural neighborhood in Texas. And I think that can happen too with community pharmacies. I think some advocacy, and I think some lobbying, contacting companies, and I think asking them, and again, bothering them and being nuisance and pestering them, because I think that actually works. Again, I've seen it happen with other kinds of establishments. So I think that that's one way. Another way is to think about transportation, because if a community pharmacy, but it has transportation to other pharmacies, that can be something. So asking your city to expand its public transportation routes is also one way. If you can't get the pharmacy in the community, then getting transportation to people, giving them transportation to where pharmacies are located. So expanding routes, expanding the times of public transportation routes. I think that's one thing that can be done right now. Again, not easy, not saying it's going to be something that happens overnight, but it's something that can be done, and I've seen done, and that can be really, really helpful to lower socioeconomic communities.
Thank you. So we're running right up to 7:30 here, and I want to give last opportunity for panelists to share any kind of closing thoughts that you have, or things that you think you want to make sure that our audience tonight hears about the different topics we've been talking about this evening. So Dr. Meyers or Dr. Amin, would you like to start us with that?
So I think the only way that we as a national community can effectively address this is to recognize that it really is, it has to be a full court press. We all have to be committed to doing it together. There's nothing more frustrating than turning on news like today and hearing that the Senate is unable to get together to pass even a very limited relief bill for folks. We're not going to get through this economically, or from a public health perspective, or from a sanity perspective, unless we all recognize that this is a genuine threat to all of us and to our national well-being. We have to come together, commit to the right kinds of behaviors, and also commit the money. It's going to be expensive to keep us from going into another super Great Depression. Part of the way we came out of that last time is because the government was willing to spend the money to make sure that we got folks employed and the services provided. We are simply going to have to do that again.
Dr. Amin?
I echo that sentiment as well. You know, on the eve of 9/11, I just think back to that day, as many of us do when it comes, and I think of how this nation came together. And I think of how we mourn together every time on 9/11 for the 2,700 plus people who died on that day. And if we want to move past this pandemic, I think we have to work together in that same fashion. We have to stop politicizing it. We have to stop screaming at one another, disrespecting one another, and just do what needs to be done so that we can move on. And I think we really have to stop in the spread of misinformation. Just because it's an article written in the media doesn't mean we have to post it. Just because it's a meme that somebody smart happened to post doesn't mean we have to share it. We need to know that what we're sharing is true and valid information so we don't spread fear and we don't have people doing the wrong things that just set us backwards. Ultimately, the goal is the same for all of us, right? We just want our pre-pandemic lives. It looks pretty good now compared to what we've been through in these last 6 months, but it is not going to happen without a wholehearted and unionized effort amongst all of us.
Thank you. Dr. Ray?
I know we're running low on time, so I'll just say be kind to each other. We're in a pandemic. Things are rough. Be kind to yourself. Some things won't get done. Some deadlines won't get met. Kids may watch more TV than you want. It's okay. It's okay. We're in a pandemic. The rules are a little bit different for us all.
Thank you. I think that's a great note to end on this evening. Again, for those of you that need the survey link that's in the chat for tonight, thank you all for your questions that you submitted. I'm sorry I wasn't able to get to all of your questions. There's many wonderful questions in there. And I think this shows the importance of this conversation. And thank you again to the panelists joining us tonight and for this conversation, and for you all for joining us this evening.